First of all, I am so happy to be here in order to meet each and every one of you in our platform. Let me express my deep pleasure about presence of Professor Mauriciano and Professor Rami from Egypt with us over this platform to discuss the interesting or uninteresting scientific issues into upcoming few minutes. Before proceeding in our presentations, let me present first the Professor Rami, and Professor Rami will bridge the presentations or will present Professor Mauriciano later on. Dr. Rami, أهلا بيك وتفضل يا فندم. شكرا.
I'm sorry for the delay due to a technical error. My laptop just decided to do an update now, so I'm joining you through my cell phone. First of all, let me thank Ever Pharmaceuticals for the opportunity to meet you all. And let me welcome a very dear friend, Professor Daphne Mauriciano, Professor of Neuroscience, Head of the Chairman of the Neuroscience Department in Nero University in Romania. And today we are talking about cerebrolysin in traumatic brain injury. So I think that my presentation is with the guys. I don't know if they can put it. Dr. Mauriciano.
Professor Rami, Professor Rami, this is such a pleasure to see us in this.
The pleasure is all mine.
Yes.
I hope to meet you again in the very near future when all the aeroplanes are flying in the air again and travel is made easy again after the COVID-19 crisis.
We do hope. It's a nice pleasure it's really a pleasure to be together even in this way.
Yes, at least we have a way now. So let's start.
Everybody, there is no presentation that will show how much we love Professor Daphne Mauriciano from Romania to be the first speaker in this presidential session, and the subject is from the neurobiology to captain concepts by Professor Daphne Mauriciano.
Thank you very much, Anwar, for the very kind introduction, and this is our great pleasure to open this, I would say, extremely relevant event. And this is, you know, the normal way to start and to step into the very complex topic of traumatic brain injury. As we know, traumatic brain injury is a very heavy burden for society, and we do believe that in all these years we have been able to develop our knowledge to understand better the mechanism of this condition, and further on to find solutions. And these solutions are really now much better if we look into the outcome of traumatic brain injury 20 years ago and today. We'll see that many advances have been done. And this was not by chance, this was definitely with the help of science. And we do believe that we have done something in this respect. And in order to organize better the environment of those who are concerned about traumatic brain injury, today and tomorrow you will have a lot of surprises and a lot of suggestions and a lot of common work. And we do hope that after these days we'll go back with a little bit different mindset and a different, I would say, capacity to organize not only our departments, but to give important hints to our healthcare systems in our countries. So I have to mention from the very beginning that TBI, it's a field with really many unmet needs in medicine and particularly in public health, as in TBI, the story, it's a lot about public health. I should not mention the financial burden, which is enormous. You know, the Americans, they have the capacity to measure almost everything, so the figures here are very heavy, 80 billions as annual burden, so we do hope that we'll be able to do more in this respect. So we also know that the incidence of TBI is increasing, and we have a challenge, particularly in relation with TBI populations, which are extremely heterogeneous in all respects: mechanism of disease, baseline prognostic risk factors, clinical severity, and of course the outcome. What we know that this generates a lot of challenges, and many pharmacological approaches have been, I would say, tested, developed. But as this disorder is so diverse, TBI is not one disease. TBI is a collection of difficult conditions, actually. But I would say that we have a lot of entities that can be described, but we have two important ends, contusion and diffuse axonal injury. In between, there is a lot of room for combinations. So basically, when we talk about contusion, we know by mechanism we can do a lot, taking in consideration the neuroprotective effects that should be delivered there. When we talk about diffuse axonal injury, we should contemplate more the idea of regeneration. So you see, as we may see together, this is really complex. With the new advent of these technologies that are now available to describe better brain function and to understand better the postlesional mechanism of action, we have understood that basically traumatic brain injury patients are very prone to develop this connection of different areas. So actually it's a connectivity disease. Traumatic brain injury put a lot of challenges in this respect, and basically we may describe this as a complex disorder of the brain, which is usually associated with small worldness, which is immediately developed after a traumatic brain injury. This is the frame of concept of connectivity and the connectome. And there is a hyperactivity of all modules, particularly during the diffuse axonal injury mechanism. If we have a look into the normal brain function, we'll see that the human brain, represented as a connectome, it's extremely complex. Today we are able, I would say rather quickly, to assess the brain connectivity and to generate a connectogram. Connectogram, it's something which describes at a certain moment all the connections of the brain. And of course we can see this in a very dynamic way. But if we look into this new science, we learn that despite the fact that we have patients with similar clinical appearance, with similar picture, you know, we realize at the end of the day that we have actually a very different substrate. So you may see here 3 patients with almost the same phenotype, clinical phenotype, but at the end of the day we realize that the situation in the first patient related to connectivity is this one, in the second patient this one, and in the third patient this one. So it's very, very clear that the impact of traumatic brain injury on each brain is totally different, and this depends very much on the lesion and biological reserve. Biological reserve is a very precious concept, and we have to contemplate more and more the capacity of the brain to balance processes after an injury, to rebalance, to adapt, and of course to regenerate. And this capacity is widespread all over the brain. So basically today we strongly believe that the task of neuro rehabilitation and the task of recovery, whatever, if it's, I would say, facilitated or spontaneous, it's to address the very complex challenge related to the dynamic adjustment of task and restive activity in the areas connected to the site of injury. So it's not so much about the injury itself, but how can brain reconnect all these areas in a normal way. The hard lesson that we have learned, it's related to post-lesional brain regulation. Today we know that after an acute brain lesion, we have a very important reaction of the brain. After an acute brain lesion, there is a continuous endogenous defense response consisting of 2 anticorrelated sequences. The first one is the sequence of neuroprotection, which is a very early sequence, mild, and at the end of the day, you know, will contribute to the protection in the sense that will have a less extended damage. And immediately after this mild and short-term oriented sequence, we'll be able to detect neuro repair. This neuro repair is extremely robust, and neuro repair will start working only when neuroprotection goes down. These 2 sequences cannot work at the same time, at the same intensity. When one is up, the other one is turned off. When protection goes down, the other one goes up, for the very simple reasons, because in the acute phase we have to fight against glutamate, for example, and many other, I would say, agents that have to be under control. But in the second sequence of the regeneration, we do need glutamate, for example, for regeneration. Without glutamate, there is no regeneration. So basically, it's a very important fact that the body will be able to keep in anticorrelation these 2 sequences. They are in anticorrelation, but they are completely entangled, and there is a huge, fantastic machinery able to work out this balance. When we have an imbalance within this mechanism, then the brain capacity to work out and to take advantage of biological reserve, it's almost 0. And we know very well that we have these important molecules that are overexpressed in different sequences of post-lesional brain regulation and the effect of neuroprotection or the effect of neuroregeneration is supported by the same molecule but in a different geometry, different synergy, different proportions. And this is an important message. So based on this knowledge, today we are able to define the pharmacological agents in relation with brain protection and recovery in monomodal agents having suppressive mechanisms, the all neuroprotectants, monomodal agents able just to stimulate, and multimodal agents able to do as brain does, basically able to initiate the whole processes within the brain in the frame of endogenous defense activities with two anticorrelated processes of protection and repair. If we look into the mechanism of action of these agents, the multimodal agents, we'll see that neuroprotection is always pleiotropic and always entangled with the second sequence of neuroregeneration. There is no chance to improve brain function without taking in consideration this. That's why majority of, I would say almost all, clinical trials conducted on the paradigm of all neuroprotection failed. And actually, today, as traumatic brain injury is such a complex condition, we realize along the way that we understood a good mechanism, how post-lesional brain regulation functions. We have these multimodal agents being able to do exactly as brain does, which is a very important breakthrough. So, I think, and we believe that there is no better pharmacological support beside all activities that we are, let's say, generating after a traumatic brain injury, the whole components of medical care, nothing would function better than these multimodal molecules. And as we know, usually neurotrophic factors are extremely active agents, and as in now, the only drug available for clinical use containing active fragments of these trophic factors is cerebrolysin, and these special peptides, they have the capacity to penetrate in every tiny little angle of the brain. They pass the blood-brain barrier, they are there, and they exert a fantastic good effect. These effects are so complex, I will not come back, but they are in the frame of this mechanism. Pleiotropic protection and, I would say, the capacity to entangle with the fundamental processes of trophicity, plasticity, and neurogenesis. Trophic factors, they are a very solid example of anticorrelation because, you know, a molecule which is a pro-neurotrophic factors may generate at a certain moment a necessary and useful cell death effect. But whenever is necessary, after the activation of the molecule, the active factor is able to generate, stimulating different receptors, a very intense activity of cell survival. So we have been stimulated by understanding of the mechanism, by the capacity of these molecules to do things, and many small trials in traumatic brain injury treatment have been conducted. And in this respect, we really developed a very large retrospective multi-center cohort study evaluating the severity and effects of cerebrolysin, and we did this in Romania. And I'm very happy that Professor Brehar is here. He will explain you something about this. It was 10 years of work, and at the end of the day, we had a fabulous cohort with around 7,600 patients. The effects have been the effects detected then have been extremely, extremely interesting and positive, and therefore the CAPTAIN concept came as a consequence, as a natural consequence, to test the capacity of these molecules in traumatic brain injury. So the context is clear, and it was a very pessimistic one back then, 10 years ago, is that in the last 30 years, no traumatic brain trial with traditional design demonstrated statistical significance using the classic monomodal suppressive molecules. So we had a problem at that time related to the understanding of mechanism of action, to the use of agents that are just inhibiting processes, not stimulating too much further on, and with methodology, because we use a conventional, I would say, methodology, which was based mostly on the single primary outcome, and usually this was Glasgow outcome scale at that time, and as an outcome we evaluated everything based on proportion of patients with favorable outcome, which was a huge limitation. And more than that, as Professor Johannes Wesser always mentioned, you know, using this binary thinking, will not guide us to success too much. And of course, we just cut a valid scale, even if that scale will bring us not too much information. We'll be able to discard even that tiny little information. If you look here at the top, that, you know, certain intervention may generate some, I would say, some effects that are detectable with a certain scale, and we may detect small step improvements, but it might be the case that we'll detect also a little bit moderate step improvement. But if we'll cut the scale simply, if we do that, then we'll end up with measuring only this tiny little effect. And the most precious, I would say, let's say, improvement possible to be measured and detected have been removed from the approach, which is not very well. And we did this even in well-conducted studies with, I would say, better approach, as we know that using just a full scale and detecting just one parameter and measuring one change is not enough. Today we know that we should use all the scales that are able to detect changes based on motor function, cognitive function, anxiety, depression, quality of life, and so on and so forth. And in the design of CAPTAIN trials, we follow the recommendation of the IMPACT group, the International Mission on Prognosis and Clinical Trial Design on Traumatic Brain Injury, and we definitely took in consideration the very important statement that outcome after TBI is by definition multidimensional. And when we talk about a multidimensional approach, we focus not only on different domains that should be analyzed, that should be, I would say, assessed in a very robust way, but also in a different approach to biometrics, to statistical, I would say, machinery. So in this respect, all relevant groups of research stated that no single measure could capture the multidimensional nature of traumatic brain injury and so on and so forth. And this is a very well-established, I would say, strategy today. But it was very complicated to operate with these concepts, as long as we haven't been able to deliver a robust statistical analysis based on this paradigm. But this era is getting to an end since some time, and we have, of course, Professor Wester will tell you more about our capacity today to entertain this multidimensional approach. Worth reading for those who would like to learn something about this and more about statistics is this fantastic book of Alex Dimitrenko. And we may say that Captain, as we mentioned in 2014 when we published the methodological paper, Captain will be the first series of trial in TBI history with a true multidimensional approach based on full outcome scales. So no dichotomization, as many scales as possible to detect relevant changes and integrated them in a very new, modern and totally dynamic, I would say, methodology of assessing these results. So as you may see, we have here all the scales exploring motor function, cognitive function, particularly related to aspects that are very much specific in traumatic brain injury, which is the dysexecutive syndrome. And you have seen, I think, these slides also before in some other meetings, but I'm sure that you are very familiar with the scales, and particularly our methodology is based on a different way of managing baseline prognostic risk factors. As we know, the heterogeneity, it's a very challenging issue. So we stratify our patient not based on Glasgow Coma Scale as we did in the past and as is done in this research in TBI, but rather based on the totally new approach which emerged from the validated cohort of the CRASH trial. And this, of course, has been done by Impact Group. This validated baseline scale is a very complex one, and it's generating a better stratification, and we are able to compare like to like. There are important parameters like age, motor score, pupillary reactivity, hypoxia, hypotension, CT classification according to the Marshall type, and TBI subarachnoid hemorrhage. All these aspects are considered and they generate stratification. So Captain project integrates cutting-edge methodology, and as you know very well, some of you maybe know, some of you not, we have been able not only to finish the project, the complex project, but also to publish the first 2 papers based on the Captain 1 trial result. This was published last year in the fall, and we have the pleasure to announce again that we had encouraging results based on Captain 1 project, and I'm very happy that Professor Veipun is here, and he did absolutely a lot in this respect. Unfortunately, we haven't been able to enroll too many patients, maybe due to the complexity of the protocol and to the limited capacity to follow up patients further on. But as a quality, the small group have been clearly demonstrating that, further, better and more thorough approach would be somehow helpful. And the results, as you may see, the 2 groups are here and expressing a very balanced characteristics. Safety profile have been absolutely similar to placebo, and the multidimensional ensemble was used. All these scales have been used due to this new methodology, to the multidimensional methodology, and this was the fantastic role of Professor Wester, who is pioneering, and now it's definitely, as you will see, developing to a total different level this methodology. And look at the results. We have been able to detect statistical significant results for this ensemble at 30 days and at 90 days with a very good signal also, and this encourages us to step forward and to develop the Captain 2 trial, and this approach was extremely successful, and we did this in Europe, and we may say that our decision was good, and this was also published also at the end of last year, and we have been even more a little bit aggressive on the treatment with a narrow therapeutic window of just 4 hours at that time, and we administered the 2 cycles of treatment for all patients, and the results have been very much rewarding us. And as you may see, balanced groups, and if you look at the 30 days, you will see, because the primary endpoint was at 90 days, at 30 days we had a very good signal, and you see that all the scales are on the winning side. And if we look at the 90 days, we have been able to detect clear, good results, and this was, I would say, something giving us reassurance that what we are doing, it's just in the right direction. And soon will be published also the meta-analysis of these 2 in a very high ranking journal, and meta-analysis was with the help of these better statistical powers have been able definitely to point towards success at 30 days, at 90 days, and we strongly believe that being here together in Cairo for the 18th AMN Congress, this is just the end of the beginning of the new approach and the new story of TBI treatment, and we do believe that we'll be able to improve in many respects the outcome of these conditions. Thank you very much, and we do hope for, I would say, dynamic input from your side along the scientific program, particularly during the workshops. Thank you very much.
nice presentation, Professor Murciano. Thank you very much. And I have a few questions from the attendees. I have actually two questions from two different attendees about your recommended maximum dose in children.
Yes, this is a good question. In children, what will depending on the intensity of the symptoms, between 0.1 and 0.2 milliliters per kilo. So if we calculate, we'll get around 5 ml per day, depending on the numbers of kilograms on each child. Yeah.
Okay. Now, another question about your study from one of the attendees. He said, what kind of patients included in the study? Are these closed head injuries, brain confusions, and did you include patients with previous history of epilepsy in the study?
No, we didn't include this. This was an exclusion criteria. Patients with epilepsy. No, it was a very well controlled. But if they would like to learn all these kind of details, they have the publication. You should have the publication because this is published and this is well explained. But the inclusion-exclusion criteria were very strict, definitely. And the treatment, I know that there is a high interest in one particular approach, prophylactic seizures in traumatic brain injury.
Yes,
prophylactic treatment for seizures. This is absolutely not accepted because anti-epileptic drugs administered just before any seizure will just jeopardize the capacity of the brain to use plasticity as a recovery mechanism. And therefore today, we are not giving prophylactic anti-epileptic drugs to any kind of TBI patients unless the patient has a real seizure. Yes, if patient does not have seizure, then will not proceed with the treatment just for a prophylactic concept. So this was also the case in Captain trial, where it was clearly stated that we will not accept any kind of patient for inclusion with prophylactic treatment. So I believe that this was the substrate of the question.
Okay, another question, it says from Dr. Nabil Mansour, Professor Nabil Mansour from Mansoura University. He said how to assess the efficacy of the drug in traumatic brain injury, giving into consideration that you have many variables.
So my presentation just explained that. So the whole presentation was about this. Actually, what we explore with our methodology, it's a totally different methodology than a classic study for traumatic brain injury using just one scale and even using dichotomy. I explained in my presentation that this study is unique for the methodology that is used. We use a methodology that put, in the right value all changes that traumatic brain injury will create for the human brain. Actually, we evaluate with the scales. We have an ensemble of scales that will cover motor, cognitive, emotional, all kind of components. All these multidimensional aspects have been integrated in one single outcome using the Alex Dimitrenko methodology, multidimensional methodology, which was approved several years ago by FDA. So this was exactly the part, but unfortunately, I can see they haven't been able to see the slides because it would have been better that the slides, the last 10 slides are very important and they haven't been on the main screen. Maybe that's why Professor was not able to exactly see that.
Okay, another question from Professor Abdel Nasser Murad. He said that cerebrolysin has multimodal effects. Is this still confined to cerebrolysin only, or are there other drugs that emerge in other drugs as well?
Thank you very much. This is a very good question. The idea is that what is a multimodal drug? A multimodal drug, it's a drug that is doing as brain does, as I also explained in my presentation. So how is the brain doing this? In the positional brain regulation, brain activates the endogenous defense mechanism. Endogenous defense mechanism consists of two sequences, neuroprotection and neurorecovery. When neuroprotection is active, neurorecovery is turned off. When protection goes down, the recovery goes up. These two sequences are anticorrelated. So a multimodal drug, it's a drug that is able to keep this biological endogenous sequence of anticorrelation between protection and regeneration, protection and recovery. So being able to entangle biologically these two sequences, because multimodality, it's not about doing many things. It's about doing exactly this sequence. So taking in consideration that neurotrophic factors are biological molecules produced by the brain for the brain, it will be difficult so far to find a different combination of molecules that are multimodal. I can tell you the same multimodality mechanism is present in the mechanism of action of some important biological molecules, like, for example, erythropoietin. Erythropoietin is a molecule with multimodal mechanism. Granulocyte stimulating factor, it's another important molecule that has a multimodal mechanism. So bottom line, biological molecules that are in our body and that work in combination with other molecules, they are multimodal. There is no one chemical molecule being multimodal. That is the idea. So the conclusion is that for the brain pathology, the only relevant multimodal agent so far is cerebrolysin, but we have to have more molecules available for treatment in the future. Is this okay? Do you hear me? Hello?
Is there a dose adjustment needed or renal impairment?
Hello?
Yes, I hear you well, Professor, but
yes.
I think Dr. Rami, do you hear Professor Murciano?
Dr. Rami, do you hear me?
I think the connection has a problem with Dr. Rami, the problem in connection.
Could be.
Oh, just wait.
Do we still have some participants?
Yes, we have now is the 270 participants, yes, now, current now.
Compositions identical? They both have the same atomic components, but in reality, they are very different. One is a graphite and the other a diamond. Biological pharmaceuticals also have a distinct composition or fingerprint that make up their unique formula for that particular drug. One drug may claim to contain similar active ingredients, but in reality, these medicines have distinctly different formulas. And different formulas mean different results. Cerebrolysin from Ever Pharma in Austria is a complex biological product manufactured in a sophisticated and complex biotechnological process. It's used worldwide for treatment of stroke, traumatic brain injuries, different forms of dementia, and other cognitive disorders. Biosimilar products, which include any minor changes in composition, concentration, or structure, must be clinically proven again and cannot easily copy the composition and efficacy of an original biological product. This is the reason why regulatory agencies like US FDA and EMA states that due to complexities, biological products are defined by their manufacturing process. Cerebrolysin is manufactured at the state-of-the-art facilities in Austria and Germany. The very precise manufacturing process is fully automated and computer monitored with very low batch-to-batch variability, ensuring superior quality control. When comparing composition data in a recent study between cerebrolysin, shown in red, and its competitors, shown in gray, the formula fingerprints clearly show differences in composition. They are not identical. The exact peptide structure, composition, and precise concentration ratio is what contributes to the proven effect of cerebrolysin in patients. What are the benefits of cerebrolysin? Treated patients with cerebrolysin are able to experience small moments but big differences in their motor recovery, daily activities, and cognition. More than 20,000 patients enrolled in more than 118 clinical studies demonstrating high efficacy and safety of cerebrolysin. And an independent trial at the Henry Ford Hospital in Detroit, USA, compared the efficacy of cerebrolysin to neural peptide preparations with the same supposed potential. And the team found that cerebrolysin was the only effective agent that significantly improved neurological outcome. If you'd like any additional information on cerebrolysin, please go to our website at cerebrolysin.com or everpharma.com. Would you consider these two compositions identical? They both have the same atomic components, but in reality, they are very different. One is a graphite and the other a diamond. Biological pharmaceuticals also have a distinct composition or fingerprint that make up their unique formula for that particular drug.
Cristiano, we have questions from Dr. Muhammad Fathi Isa about TBI of the frontal lobe contusions. Is cerebrolysin in this case can induce more irritability, insomnia, and even seizure with this case?
صوت عن الدكتور مرشانو مش ظاهر يا جماعه.
افتح صوت الدكتور مرشانو وهو بيجاوب.
For what reason my microphone was moved by somebody. So I'm coming back with my answer. In traumatic brain injury, cerebrolysin per se will not induce any seizure and not irritability. We have thousands of patients treated. If you look into the cohort study published 5 years ago, when we have 7,800 patients, you will never see these effects, okay? So
Yes.
if you have a seizure due to traumatic brain injury, you should wait. You should not administrate anti-epileptic drugs, and you should wait until you will have the next seizure. And if the seizures are dangerous, then you will treat the seizure, and you may go with a normal dose of cerebrolysin.
Okay, Dr. Marciano, do you have any recommendation of using of cerebrolysin with borderline kidney function patient or kidney functions impaired kidney function patient?
So cerebrolysin is an extremely well tolerated drug. It's much more better tolerated than any chemical drug. Okay, do you hear me? So if you have a renal failure, you should not be concerned at all if the value of creatinine is around 3. If the value of creatinine will go up to 4, 5, 6, then after 3, you may reduce the dose of cerebrolysin with 10% for each unit of creatinine which goes up. So basically, this is just for cautiousness. So it's not about that. It just is more a formal indication for safety reason, because in all we have thousands of patients and we haven't seen adverse like that.
We got your point, Professor Mauriciano. We have one more extra questions about another neuropathic pain apart from TBI and stroke cases. Do we have any experience with another indications like neuropathy and different neuropathic pain in different areas along the body itself?
Yes, taken in consideration the fact that neuropathic pain is the result of pathological plasticity. All types of neuropathic pain are the result of pathological plasticity. So basically, we may use cerebrolysin in order to stabilize plasticity, and this is the mechanism of action. There are some studies in diabetic polyneuropathy. So in case of diabetes and peripheral neuropathies, we may use cerebrolysin, and there are some studies, but this was not, as long as I know, this was not in the focus of the development so far. The effect is good.
Dr. Mauriciano, yes. We have another questions about combinations. Dr. Tarif asked about the can we adjust the dose of low molecular weight heparin or anticoagulant in general when are using these drugs with the cerebrolysin?
No, there is no interaction and there is absolutely no need to adjust anything. There is no biological or chemical interaction, because we have chemical interactions and biological interactions. So there is no interaction.
No interaction. I think this is the last questions from Dr. Ahmed Dahshan. He asking about for how long or what is the maximum period I can use cerebrolysin with a patient post-traumatic brain injury. What is the maximum limit to continue the use of the cerebrolysin?
So I will answer this in a very clear way. The protocol, because there are approved protocols for cerebrolysin. The protocol is the following. In the acute phase, we give usually 50 ml, there's 50 milliliter of cerebrolysin every day for 10 to 20 days, according to the patient clinical condition, according to the severity. Usually we give 50 milliliters for 10 to 20 days. After that, we have a stop, let's say, but not too long, maximum 15 to 20 days, and then we'll repeat the cycle of treatment. So in the acute phase, we give this high dose rather, and then we give every month, maybe 30 ml or minimum 10 milliliters, 10 ml, as long as patient condition is improving. So you may give 1 year, and after that, if you see progress for patient condition, this is good. If you see recovery, then if you have reached a certain plateau of the recovery, you should administer cerebrolysin at least once in 3 months to keep that situation. If the patient condition is getting worse a little bit, then you may increase again the dose. But yes, we may use an IV shot, of cerebrolysin. Usually we may give in the chronic intermittent treatment, in the repetitive cycles, when we give 10 ml, we may give it IV. but we should do it slowly, 10 ml in 5 to 8 minutes, okay? So this is the rule, 5 to 8 minutes. We give it slowly. There is no
5 to 8.
5 to 8 minutes because the patient will feel a little bit a kind of will have the feeling of getting hot, yeah.
Yes,
And
yes.
And then we have to go slowly. It's no danger. In fact, it's
Yes.
no danger, but this is very cautious. We may give it as a
Yes.
shot.
Dr. Mauriciano, excuse me, I have received last questions, please, from Dr. Hosni Salama. He's asking about cerebrolysin is a cornerstone in TBI now, and a lot of HCPs are worldwide using in a different regimen cerebrolysin. The question is, we can't balance between the cost of product and the continuity or long continuity of such a treatment. So the question is, do you think that the response is dose dependent? I believe these questions are arising from inside of reduction of the using dose. But he asking about the dose of cerebrolysin. It can be the response over the patient. It can dose dependent.
This is a so well established finding. It's extremely clear, demonstrated finding. We have the study of the cohort with 7,800 patients, and we have 2 dose regimen in that study with 20 ml with the 30
okay.
ml. Okay. Even by mechanism of action, cerebrolysin has a dose-dependent effect. But in the clinical research, we have demonstrated repetitively that is dose-dependent because the results are better, especially in the acute treatment, if the dose is adjusted at the highest level. And if we have a high level, like 30, 50, results are a little bit better than giving 20 ml, for example, in the acute phase. So my answer, yes, it's a dose dependent. But I'll tell you, there are pharmacoeconomical studies and cost effectiveness proving that cerebrolysin it's not expensive if you consider all the costs, because the cost will be tremendously reduced by patient improvement. So the cheapest way is to administrate high dose. Yes, only in very, I would say, in the system with limited understanding of the concept of cost effectiveness, somebody may look only into very, very, very direct costs. Yeah, because you have to look in the whole cost effectiveness approach. Yes. So high dose term is the cheapest.
Yes, yes, I got your point. Dr. Mauriciano, we have finished now all questions that we have received, and we direct by all thankfulness of Dr. Mauriciano. Dr. Mauriciano, or Daphne Mauriciano, is a president of European Federation of Neurorehabilitation and co-chairman of EAN, and Dr. Mauriciano also is a professor of neurology in Romania. We are gratitude for your presence with us today, and we hope to meet you in upcoming webinar in the next time.
Thank you very much. It was a great pleasure also for me to be with you, and especially to see my old friend Professor Rami, and to have the chance of discussing this important topic of traumatic brain injury. Thank you very much.
Thank you so much, dear Professor Daphne. Thank you so much. Thank you so much.
Hello, everyone. My name is Rami Amin, professor of neurosurgery in Cairo University. And I would like to welcome everyone from the Gulf states, from Europe, from Kenya, and from Libya. And following the magnificent presentation of my dear friend, Professor Daphne Morciano, I'm giving my very concise presentation about the Egyptian experience using the cerebrolysin in traumatic brain injury. Now, we all know that traumatic brain injury is the definition is non-degenerative, non-congenital insult to the brain due to an external mechanical force. This could lead to a temporary or a permanent impairment of cognitive, physical, psychological functions with or without an initial or sustained altered conscious level. The mechanism of injury is a blunt injury, a penetrating injury. But what I want to concentrate upon today is because I'm a neurosurgeon actually, because about the surgical, post-surgical and post-endovascular procedures. And we have been using cerebrolysin for the past 4 years. Myself, I've been using it for the past 4 years after certain surgeries, and if with endovascular procedures, complications do take place or deficits do take place. Now, we all know that primary injury, you cannot prevent primary injury except by prevention of the mechanical trauma itself. Secondary injury is damaged. That takes days or hours after the injury. You have to prevent hypoxia and ischemia. The pathophysiology is uncontrolled apoptosis, excessive neuroinflammation, formation of free radicals, a cytotoxicity, neuronal dysregulation, and neurodegeneration. Actually, if you look at these all 6 items, this is the 6 items where cerebrolysin works. It works perfectly in these 6 items. The Egyptian experience with cerebrolysin, like I said, in the past 4 years, most of the patients are in Egypt's biggest private hospital. We have very large number of cranial endovascular procedures taking place in this hospital. And when we first started, like 3 years ago, in the first year, we used to give cerebrolysin only to patients with traumas that we don't have any cause to increase the intracranial pressure. No intracerebral hematomas, no subdural hematomas, not an angry brain. But then in the following year, we're starting using it. Also, for patients with post-concussion syndrome, where the symptoms stay for more than 3 days, unexplained. Or, like I said earlier, the most important item to me is the post-surgical and post-endovascular procedures. And I'm going to talk in detail about that. For neurosurgeons that are joining us, if you do a subfrontal or an oblique subfrontal, sometimes even with retractile brain surgery, the mere retraction or the mere receding of the frontal lobe yields some frontal manifestations post-operatively, some personality changes. This improves dramatically with cerebrolysin. Also, if you're doing a sylvian splitting fissure procedure, like the pterional approach, especially on the dominant side, you can have some dysphasia post-operative. You do a CT scan, it looks normal, but the patient has dysphasia. We give this patient cerebrolysin. Also, cerebellopontine angle procedures, the retraction of the cerebellum, and even the concussion that sometimes takes place in the lower cranial nerves and do some bulbar symptoms. Also, cerebrolysin works perfectly. Sometimes a spasm or a temporary ischemia takes place when you are doing endovascular procedures like embolization or coiling for aneurysms. And again, we used the cerebrolysin. The numbers I'm talking are now, I don't have statistics, but I'm talking about maybe 200, 250 patients. And if Dr. Morciano is following me, like I said earlier in one of the meetings, that we want to put this into context and do a joint study to have a statistical valid study. For post-operative patients, the problem could be due to the retraction, to the dissection, or to the ischemia, or to all of these. and you do a follow-up CT scan. The patient has deficit, but the post-operative CT scan looks beautiful. You give cerebrolysin, and there is very speedy recovery. The cerebrolysin we used, I know somebody have been asking about the dose. Usually, the dose is between 10 milliliters to 50 milliliters in adult patients. Usually, you started with a dose of 30 milligrams daily intravenously in 3 divided doses for adults. Mild patients, I will give them only 10 milliliter daily in a single IV dose or in 2 divided intramuscular doses. The duration was for 4 weeks, and usually I give them 5 days consecutively, and then arrest or off the dose for 2 days, and then 5 days, and so on for 4 consecutive weeks. The clinical observations we have now, I have now patients that has received 4 traumatic brain injury or even post-operative for 4 years now. I have patients 4 years now, and I have a follow-up up to 4 years, like I said, and it revealed that the administration of cerebrolysin is associated with improved functional outcome in patients measured at the Glasgow Coma Scale in the early phase and the modified Rankin Scale in the later cases. Cerebrolysin has rapid effect on patients, especially in the post-concussion syndrome, and resulted in nearly a speedy full recovery. Patients with radiological or clinical evidence of increased intracranial pressure, cerebrolysin, without radiological evidence of increased intracranial pressure receiving cerebrolysin, they made a steady improvement over the first 4 weeks on the treatment, both on the Glasgow Coma score and the modified Rankin score. The cognitive functions, the motor recovery, and the balance, and the speech, they did much better as regard improvement than visual, smell, or taste sensation. Also, third and sixth nerve pulses, they did a bit less in improvement compared to motor recovery, balance, speech, and cognitive functions. In conclusion, cerebrolysin is a multimodality neuropeptide drug which improves and speeds the brain neuro recovery, and our clinical observations confirms its efficacy in traumatic brain edema, especially in post-operative deficits. Thank you. Hello again. I'm happy to receive your questions. So the first question from Dr. Sam Hammer: if the patient is already epileptic, could you use cerebrolysin under coverage of anti-epileptics? Well, definitely, I will use cerebrolysin if I have a deficit and the post-operative CT or the follow-up CT for a trauma patient shows no intracranial hematomas, and if the patient is covered by anti-epileptic, definitely I will use it. Second question from, there is no name, it's Galaxy Note. What is the number of patients you have treated and inclusion criteria? I don't, like I said, I don't have statistics, but the number is between 200 and 250 patients over the past 4 years. Inclusion criteria, like I said earlier, is the patient, for post-traumatic patients, are the patient without CT showing increased intracranial pressure and without a surgically correctable problem. For post-operative patients, if you do, like I said, if you oblique subfrontal, if you do a trional with Sylvian splitting, and you have a aphasia, definitely you can use cerebrolysin with excellent improvement. Post-concussion syndrome, usually of mild TBI, all have a smooth recovery. Yes, they will do. Another question from Dr. Bishoy Wadia: when to increase the dose if no improvement? Usually you start, like in adults, you start with a dose of 30 milliliters daily on 3 divided IV doses. You can increase the dose maximum to 50 milliliters if there is no improvement after the first week. Another question regarding cortexin: do you found the cerebrolysin has extra benefit in clinical practice on hypoxic encephalopathy? In hypoxic encephalopathy, yes, it has definite use. I can't read actually the question. Cortexin, I don't know what's cortexin. Can you use cerebrolysin in cases with seizures? Already Dr. Morciano answered that. And again, what about the cerebrolysin in patients with seizures secondary to TBI? I think you can use cerebrolysin in patients with seizures after traumatic brain edema, maybe in a later phase and under the coverage of anti-epileptics, because you're not only looking to control. If the seizures are controlled with the anti-epileptic, you can start using the cerebrolysin to improve the functional recovery of the patient and to be able to go back to his work, to be functional in the society again. Any more questions? I don't have any more questions here. So if anybody wants to ask a question before we conclude the session.
Okay.
No.
Still we have questions, Mr. Ahmed?
Yes.
Okay.
I have another question now. It says cerebrolysin can be epileptogenic in pediatrics with traumatic brain edema. What is the dose in pediatrics? Dr. Morciano answered that it's 0.2 per kg. Is there dose adjustment with severe renal impairment? Already this was answered by Dr. Morciano. For how long can you use cerebrolysin, as I saw people use to take it for more than 2 years? Well, I said that earlier. Usually what I do is use it for 5 days and then 2 days off for 4 weeks consecutive. And then you reevaluate. If you have improvement, you can continue the dose, monitor the renal functions, and continue the dose so long that you have keep having improvement with the cerebrolysin. Does peripheral nervous system patient benefit from cerebrolysin, and how far? This is actually a very good question.
So I have answered
this. Is not.
Yes.
Dr. Marciano, do you want to?
Yeah, I have answered this. I can repeat this, of course. Shall I repeat?
Yeah, if you wish.
Yes, of course. If you invite me, I will always insist on that. Cerebrolysin has a very good effect in neuropathic pain, because neuropathic pain has a pathological plasticity mechanism. And therefore, there are some studies, of course, very few, and it was not a priority for the company to develop this kind of indication. But our clinical experience proved that we may use this in a very nice way with some very good results. And we are very much experienced in this respect, as we have treated many patients. We have treated, I personally, peripheral problems. And we may say, of course, we describe this as an off-label utilization of cerebrolysin, but still, we have been able to demonstrate and to prove some good clinical results, particularly in diabetes.
Yeah.
In peripheral,
Can I add also that we have other uses of cerebrolysin, like in facial nerve palsy as well. Obviously, you can use it also for dementia.
Oh, of course.
And yeah. We have a question here. It's for you, actually, Dr. Marciano, from Dr. Mahmoud Taha, professor of neurosurgery in Zaazee University. And he said, Cortexin is a new Russian drug which acts as a neurotropic drug, and it's called Cortexin Vista. You have any information about that?
Yes, there are several drugs that claim to have important, I would say, neurotrophic effect. That's true. I don't have personal experience. Personally, my experience is with the original drug. The Cortexin, it's a drug, but it's used only in Russia. Might be a good molecule, but I don't have the experience with Cortexin. I also may say that there are also some other products that try to somehow create a kind of biosimilarity, but the effects have not been proved. There is no clinical trial to prove that these molecules are doing somehow well, or to have statistical significant results in any respect. But unfortunately, they use the cerebrolysin data. Yes, but there now, if you like to demonstrate something with a certain drug, then you have to develop clinical trials, and we need evidence-based. So what lacks is the evidence-based with these drugs. That's the problem.
Another question here, Dr. Marciano said, what about the use of cerebrolysin? If you're using cerebrolysin with cerebrolysin?
No, we'll not stop cerebrolysin. We'll just manage the seizures according to the guidelines, and we'll continue normally with cerebrolysin. That is clear.
Okay. So I don't think we have any more questions.
Thank you very much.
Ramon?
Okay. Thank you again for these interesting presentations. And now we have to convey for Dr. Osama Subih about announcement of our prizes for our HCPs attended this platform or webinar. Dr. Osama Subih will start the announcement of figures or prizes. Dr. Osama, here you go.
Yeah. Okay. I can start now?
Yes, please.
Yes.
Yes. First of all, I want to introduce myself for you. I'm Osama Sobeh. I'm Country Sales Director ever and BB4. And it's my pleasure to be with you at this very elegant webinar. First, I would like to thank our eminent speaker, Professor Marciano, for the elegant presentation. I really enjoyed a lot the level of information, the level of information that we deliver today. Also, I'd like to thank all participants from everywhere, either from Egypt, our professor from Egypt, and also from Kenya, from Libya, from Gulf area, and from everywhere joined this meeting. I hope that you are really enjoyed that as I enjoyed a lot this session. Now it's a part of to announce the winners. We have today, we have 12 winners. The first group, 6 winners, will be eligible for a voucher from Jumia online shopping. And the second group, also 6, will be eligible for a voucher from Jumia with 500 Egyptian pound. So let's to announce the first group with 1,000 Egyptian pound from Jumia. And this is to the next one. Let's to start with the first winner. The first winner will be Professor Shihab El-Khadrawi. Congratulations, Dr. Shihab. Okay. Dr. Shihab will be eligible for a voucher with 1,000 Egyptian pound. The second winner will be Dr. Nabil Mansour. Nabil Mansour. Congratulations, Professor Nabil. The third winner, Professor Ahmed El-Sirwi. Ahmed El-Sirwi. Congratulations, Dr. Ahmed. The fourth winner is Professor Tariq Tarif, Dr. Tariq Tarif. Congratulations, Dr. Tariq. The fifth winner will be Professor Hamdi El-Nabawi. Hamdi El-Nabawi. Okay, congratulations, Professor Hamdi. The last winner for the first group, Professor Walid Shahata. Professor Walid Shahata. Congratulations, Professor Walid. So we'll go for the second group, which will be eligible for a voucher with 500 Egyptian pounds. The first winner is Professor Walid El-Houshi. Walid El-Houshi. Congratulations, Professor Walid. The second one, Professor Ahmed El-Zayat. Congratulations, Professor Ahmed. Professor Muhammad Saeed. Professor Muhammad Saeed. Congratulations, Professor Muhammad. Professor Basim Fouda. Professor Basim Fouda. Congratulations, Professor Basim. Professor Abdel Nasser Murad. Professor Abdel Nasser Murad. Congratulations, Professor Abdel Nasser. Last one. Professor Wa'il Mu'bil. Professor Wa'il Mu'bil. Congratulations, Professor Wa'il. So these are the winners, 12 winners today, and you will receive the voucher number on SMS, most probably by tomorrow. Thanks for all the audience, thanks for the speakers, thanks for all, and hope to be with us in the next webinar, inshallah. Thank you so much.
Thank you very much.
Finally, we have to thank each and every one was with us today. And we haven't enough word to express our pleasure with our customer in this platform. Before ending our webinar, I remind each and every one of you good self by our closed group over Facebook. This is what we are calling a Cerebrolysin expert. We are looking forward to see each and every one of you over this group. This group is specialized for a neurosurgery and neurology specialty, and this closed group we can share over it a last update over neurology science or neuroscience, and also we post many updates about COVID and Corona. We are looking forward to seeing you there. And finally, I would like to thank each and every one of you, and thank you for your time all. Thank you.